Welcome back. What we're going to do now is we're going to start moving into how we decide what type of occlusal appliance we may prescribe for a patient. And we're actually going to start by talking about sort of the mechanics of different occlusal appliances. And when I say mechanics, what I'm really referring to is how does, for example, an anterior bite plane affect joints and muscles? How does a full coverage appliance affect joints and muscles? And we're going to talk about it both in clenching muscle activity and in excursive, mandibular translation movements. So as we go into this, what we really want to try and identify is that you become clear as to what it is you're trying to accomplish by prescribing an appliance, and that, along with your exam, is going to help you choose the occlusal appliance. We also want to consider how often is the patient going to wear it. Is it going to be every night? Is it going to be how many hours a day? So we need to walk through all of those kinds of decisions. And all occlusal appliances do have some risks. Some have higher risks than others. So we want to be able to identify as we go through these future lessons, what are the risks that come with each of these different appliances. So basically this chart essentially is on the left side the different appliances that you can choose from, and across the top are the different reasons that you might pick an occlusal appliance. So we'll talk throughout these future lessons about anterior bite planes. Those are appliances that have no posterior occlusion. We'll talk about full coverage appliances that are built in a seated condylar position, centric relation, if you will, and they also have a ramp on them for anterior guidance. That would be a very typical, classic full coverage occlusal appliance. We will talk about full coverage appliances that are built in a seated condylar position but are actually built as a flat appliance without anterior guidance. We'll talk about full coverage appliances that are not built in a seated condylar position, but they do have anterior guidance built in them. We'll talk about full coverage appliances that are not built in a seated condylar position, but they're actually totally flat. And we'll talk about full coverage occlusal appliances that are actually built so the mandible has to close in a certain position, what we'll call a directive appliance. And all of those full coverage appliances, you also have the choice of, do you make it a maxillary appliance or do you make it a mandibular appliance? And then we'll have what's called a posterior pivot appliance. A posterior pivot appliance actually has no anterior occlusion. And then finally, we'll talk in, again, future lessons about full coverage soft appliances. Do we use them, and if so, when? Why do we pick appliances? Well, one reason is for diagnosis. So when we're trying to identify, is this a muscle pain patient or a joint pain patient, like Kathy that we saw in the previous two lessons, there are appliances that if a patient has joint issues can make them worse. So sometimes, and an anterior bite plane would be one of those appliances, sometimes we will use an anterior bite plane to see how the patient responds to it to help us with diagnosis. Sometimes we want to deprogram muscles, or we actually want to treat muscle pain. And so we want, again, an appliance that's very effective at managing muscle activity. Sometimes we need to actually treat joint pain when the mandible's moving. And when we need to treat joint pain, you're going to see shortly, we need a full coverage appliance. And when we need a full coverage appliance that manages pain during movement, usually we don't want a lot of anterior guidance. We want a flat appliance. Sometimes we need to manage a patient whose condyles can't be seated. And again, that typically means a full coverage appliance and the occlusion's built in a more forward position. Sometimes that's a directive appliance. It makes them close there. And then sometimes we want to advance the mandible for a number of reasons, breathing disorders being one of them. And again, typically that would be a directive appliance. You would know it as an apnea type appliance. And then finally, a very common reason we prescribe appliances is we want to protect teeth from wear or fracture, or we want to protect porcelain from wear or fracture. So That chart really is, by the time this course is done, we'll have filled out this chart so that for each of those different reasons we use appliances, we'll identify what appliances typically are a good choice. Speaking from a mechanical perspective, what you're going to learn, though, is sometimes there's reasons appliances work or don't work, and it's not mechanical, it's more physiologic or biologic, if you will. So to understand the fundamentals of when do we need a full coverage appliance versus some of the other appliances, the place that we'll start is just the relationship between the bite and the load on the jaw joint. Jaw joint loading is dependent upon having posterior occlusion. If you don't have posterior occlusion, the joint gets loaded more. If you have posterior occlusion, the joint gets loaded less. It's just the mechanics of the posterior teeth absorbing bite force. So when we think about it, if we look at literature, and this is classic literature from the 80s, these studies all find basically the same thing. When you have anterior-only contact, such as an anterior bite plane or an NTI, 60% of the load from the muscle's contraction is going to go to the temporomandibular joint. If you take away that anterior appliance and put in a full coverage appliance, with how now has second molar contact, now only 5% of the contraction of the muscle goes to the joint. So when we have joints that are in need of assistance because we want to reduce loading for them, pretty much 100% of the time I'm using a full coverage appliance. There are people that will tell you that the anterior appliances will shut the muscles down, and since the muscles are shut down, the joint won't be loaded, but there's a lot of evidence to suggest that that may not be true for sure in every patient. I want to be safer. I don't want the joint overloaded. Now, what really determines whether the joint's symptomatic or not is the actual condition of the joint. So if we have healthy joints that can be loaded comfortably, anterior bite planes are perfectly safe most of the time. But when you have a joint that has disc displacement issues or degenerative issues, full coverage appliances for sure. Now that's the occlusion in jaw joints. Now let's talk about occlusion in muscles, so the occlusion on appliances and muscles. Let's talk about clenching first. So if we were going to treat somebody who has a habit of clenching and their muscles are tender and sore because of clenching frequently, what kind of an appliance would you wear? So again, the 1980s was sort of a classic decade when all of this research was done. So Arturo Mans brought people in and he put electrodes on masseter muscles, temporalis muscles, and then using different types of appliances, he had the patient clench. And what he did is he mapped electrical activity of the masseter muscle. So here is the masseter activity when the patient clenched on their own teeth, no appliance. You put in a full coverage appliance that's equilibrated so it hits evenly on all the teeth, and you ask them to clench. And what you discover is the patients can actually clench harder. As you open vertical slightly, the muscles actually can produce more activity. Then what he did is he put in an anterior-only appliance, only across the 6 anterior teeth. Now you ask them to clench as hard as they can, and you get a significant reduction in muscle activity. But you need to know that doesn't happen in every patient. One of the problems of occlusion is we would like to think, well, this is what happens for everybody. If I give everybody an anterior bite plane, they'll stop clenching. Not true. Roughly 20% of patients actually clench harder on an appliance, and roughly 20% will clench on an anterior bite plane just as hard as they do a full coverage appliance. A very simple test for that is put your fingers on your own masseters, bite on your back teeth and squeeze, feel your masseter contraction. Now go out end to end on your centrals, fingers on your masseters and clench, and see if your masseters shut down when you're end to end as opposed to when you're clenching on your back teeth. You can do that for your patients. If your patients' masseters clench as hard when they're on their centrals as they do when they're on their molars, that's not a good patient for an anterior-only appliance. Now, when the appliance goes back to the premolars, suddenly they can clench harder again. And if we put in a posterior-only appliance, sure enough, they can clench just as hard as if it was a full coverage appliance. So what we learn in clenching for patients who clench is that, in fact, anterior-only appliances for most patients is probably the most effective appliance at reducing clenching activity, but it doesn't work in everybody. That's why you're going to have some patients with muscle pain, and you put them in an anterior appliance, and they may not get any better, and you say, well, I thought this was supposed to stop the clenching. Now, it may also be that there's another reason they don't get better, and that has to do with breathing disorders and airway, that perhaps, in fact, that's why they're clenching. It doesn't have to do with whether you have anterior occlusion or posterior occlusion. Now, what about anterior guidance on full coverage appliances? So when the mandible moves left, move right, move forward, anterior guidance would mean that the posterior teeth separate. So the occlusion is only on the anterior part of the appliance. Again, if we go back and we start looking at research, and we're going to use some more Arturo Mann's work, he did appliances where he built in group function. So when the patient moved to the right, for example, all of the teeth on the right side would touch the appliance. And then he altered the appliance, so by building up the canine, the patient, when they moved right, only had canine guidance. None of the other teeth touched. Electrodes again on masseter muscle. You go through the same thing. You have the patient move left. You measure the electrical activity. And what you discover is, in fact, virtually every time group function produced more activity than canine guidance. So for most patients, again, not all, most patients, canine or anterior guidance on an appliance will help reduce muscle activity during excursive movements. But it's not going to be 100% of people does it work on. So when we're thinking about joint pain patients, we're typically thinking about full coverage appliances often that are flat. When we're thinking about muscle pain patients who have normal healthy joints, we could be thinking about anterior bite planes, or we could be thinking about full coverage appliances that have anterior guidance built into them. None of those studies really looked at was a fact that occurs over time when we change somebody's occlusion. And that is, once you alter somebody's bite and you look at it from a research perspective, you could say, well, see, if you use canine guidance, it shuts muscles down more than group function. But that's all done during one appointment, during a study that lasts an hour maybe. What happens if you change the group function into canine guidance? Does it still shut muscles down 3 months later? And those studies don't answer that. There are studies that have looked at that, at what happens to muscle activity prior to inserting an appliance, inserting the appliance, following it for 1 week, following the muscles for a month, following the muscles for 3 months. What you tend to see is that you've had your pre-treatment muscle activity level, you put the appliance in, you start to get some reduction. Over the course of a week, it's less. By a month, it's even farther less. But by 3 months, it comes back up to where it started pre-treatment. And so some of the challenges of occlusion is we've wanted to think that those studies on muscles from the 80s, that if we created that anterior guidance pattern, those muscles would stay quiet forever. Well, Rodolfo Morales, who was part of Arturo Mann's group back in the 1980s, came up in 2008 with this very brilliant idea of getting 30 people who had naturally occurring group function and naturally occurring canine guidance, bringing them in the laboratory, putting electrodes on their masseter, and evaluating did the canine guidance group have significantly less muscle activity than the group function group. So one of the first things he did is he had the patients clench on their natural teeth, and he measured that amount of masseter activity. He then asked them to grind out to the side, and what you notice is as you grind to the side, your masseter is much quieter than when you're clenching on your own teeth in the posterior. He then had them clench edge to edge, still really reduced compared to clenching in your intercuspal position, and he then had them grind back to center. Then he looked at the same exact positions, comparing the people with naturally occurring group function to naturally occurring canine guidance, and what he discovered was the two groups were identical. There was no statistical difference. People that had naturally occurring group function did not have any more muscle activity than people that had naturally occurring canine guidance. And so my point about the occlusion and muscle activity is, I know what we've been taught and I know what the research has said through all the years of starting back in the early 80s, but the evidence today is that what we do to the occlusion, if we leave them in that new occlusion, their muscle activity probably moves back towards their pre-treatment level. But as a general rule, the way I think about appliances is joint pain patients, full coverage appliances, typically flat plane, clenching patients, healthy joints, anterior bite planes, clenching patients or bruxing patients, typically it's a full coverage appliance and it will have a shallow ramp, hopefully shutting some of the muscles off. So that's sort of an overview of how we think about appliances and how we think about choosing them. What we'll do in the next lessons is we'll go through the specifics of different appliances along with what their risks are. So I look forward to seeing you then.